So my name is Kulasekararaj. I'm a consultant based at King's College Hospital. So I do have an interest in aplastic anemia, but more importantly, I'm passionate about the disease and management and care of people with aplastic anemia. Obviously, King's, as you know, is a sort of a reputed center for aplastic anemia from the legacy of number of people, especially Professor Judith Marsh was my mentor. So there you go. Quite a lot of people might know her, who has happily retired now and left the left the mantle to other people. So and she's well anyway. So there you go. So I'm happy to take questions, and I think thank you for submitting all the questions as well. Again, just at the outset itself, some of the things I'm going to say is definitely not evidence-based because this is going into territory of where the rarity of the condition makes it very, very difficult to give you very concrete opinions. So please, whatever I say, take it with a bit of with a pinch of salt, because at the end of the day, it's important to make your own judgment as well. Some of it is very much evidence-based, so I will tell you that when it is very much evidence-based. But again, we are evolving in this area of viral infections, aplastic anemia, vaccinations as well. So I think a lot and lots to do, including research to understand it further. And we are proud to say we are doing some of that research as well. So it will be great to build on that. So I think we could just talk about this question for the next 1 hour, because it is definitely a topic which is quite controversial and quite can bring in number of emotions for people as well, because of the historical data. So just going back, any vaccination, what it does is it triggers an immune response in somebody's body. And that immune response will be protective against the particular virus or what you're vaccinated against. But as you all very well know, aplastic anemia is a disease where your immune system is abnormal, that the immune system tries to kill the stem cells and then causes low blood counts. So any viral infection or any vaccination can potentially trigger a very abnormal immune response. And occasionally that immune response can be counterproductive for somebody with aplastic anemia, i.e. that immune response might be beneficial for the virus, but or getting rid of the virus, but that same immune system, which is abnormal, can sometimes attack the stem cells. So there has always been in the literature cases where vaccination has triggered relapse of aplastic anemia, or vaccination itself has, for some people, caused them to develop aplastic anemia. So i.e. they were well, they had the vaccine, and then they developed aplastic anemia. But the caveat here is, unfortunately, the medical literature will always report these kind of cases. So if there is one case of vaccine which causes aplastic anemia, that will be reported, not the millions of patients who had vaccines and did not develop aplastic anemia or abnormality. So the general tendency has always been, very much in UK, has always been to say, avoid flu vaccine if possible, because there is a theoretical risk, there is a chance that 1 or 2 patients might have a relapse of aplastic anemia, or aplastic anemia can happen. But this is only predominantly in UK, because in Professor Marsh's days and other things, there have been 2 or 3 cases which has been reported. So there has always been a skepticism around giving flu vaccination. But when I speak to colleagues all around the world, they say we would definitely go ahead with vaccination. And for anything in life, as you very well know, it's a risk balance, is it? So what's the chance that the flu is going to be significantly worse compared to the theoretical risk that a vaccination will induce your immune system to attack and give aplastic anemia? So I've not answered the question yet, but I personally feel that everybody needs to make their individual choices. And I would say, because the worry is for the last 2 to 3 years, all these common cold viruses have stayed behind because everything we talked about was COVID, COVID, COVID. My worry is all these common cold viruses and flu viruses could potentially come up with a bit of a vengeance because they've not seen anybody to infect for the last many years. So I would cautiously advise that we should do it, but be careful that you do a blood count post-vaccination at some point, just to be careful. And even if there are signs that there is potentially any bruising or anything come up, just have a blood test done, because it might be temporally linked to the vaccination. So I would suggest that we have extra vigilance in monitoring these group of patients. And this is what I'm saying is predominantly applicable for people with aplastic anemia who've not had a transplant, stem cell transplant. People who have had a stem cell transplant, I would suggest that all the vaccinations which are advised by the transplant team, and it's part of the schedule, should be given routinely so that the immune system has got ability to mount a response against flu. Hope I was able to put it in a bit of a nutshell. Apologies for a long-winded answer to a short question, but there is no direct answer to this, but it's about balancing the risk benefits is what I would say. Yeah, so this is a very, very important question. So for people who are not aware of, the kids get the flu vaccine as drops and they are live vaccine, while the adults get it as a jab or an injection, which is a killed vaccine or a virus which has been killed, and then you give it as a vaccine. So the reason people are advising patients whose immune system is down, like transplant or aplastic anemia, is because once your grandchildren have got that live vaccine, there is a possibility that the virus in the live vaccine can give flu to the person looking after them, like a grandparent or a parent type of thing. And that is like you're catching a flu. So that's what you have to avoid. So there are a couple of ways around it. The first way is if they get the flu killed vaccine, the drops nasal vaccine, you have to keep away for them for a couple of weeks, which I know you will come back and tell me that's not possible. I'm not going to do that, which I agree. There is an option that the kid gets a killed vaccine, which unfortunately it's going to be an injection. Yeah. But again, it's a balance. So if you have aplastic anemia who've been treated and off the drugs for immune system, you're very well, you can balance the risk and say, maybe I can take that risk because my immune system could hold. But if your immune system is still very much suppressed, you're still on a higher dose of cyclosporin, then it's better to avoid that, either avoiding the vaccination in the grandchild or child, or keeping away from them for a certain period until the live virus is away from the system, which would be at least a couple of weeks. And so at the moment, if I'm not wrong, the current COVID vaccine, which is being offered, the winter-autumn vaccine, they call it as a bivalent, which means it's got activity against the conventional COVID. Yeah. I'm not supposed to say Wuhan, but the old alpha variant, and also activity against the Omicron variant. So that's why it's called a bivalent vaccine, and it's predominantly done by Moderna. But my understanding is there is a big plan to bring in a combined COVID and a flu vaccination for at some point in the future. But what I don't know yet is what are the developments around that, and where are we with that? Because at least in UK, that has not been rolled out yet. So the only thing which has been rolled out is the bivalent COVID vaccine. Sam, what was the question? Is it mainly COVID after transplant, COVID vaccine?
Yes, it was basically the person who's post-transplant, and I've been in the situation myself. They wanted to know whether it was safe for For example, when they go to the vaccination centre, is it safe for them to have both the flu vaccination and the COVID vaccination in the same session?
Yeah, I think conventionally, I always say if you can stagger vaccinations, it's always better, because then you wouldn't know what is causing what as well. That's a general principle, anything in medicine, is it? Like, you don't want to have too many things at the same time, because then you wouldn't know what did what, or what helped, or what you had the side effects. And you don't want to have two arms out of action for a few days, is it? So you need at least one arm to work on. So I probably would stagger it if it's possible. I don't know. It's a question of where do we stop, is it? So that's always a tricky thing to answer, because it's been shown that, okay, so let me rephrase that question in a different way. So we were all worried about patients with aplastic anemia and PNH for twofold reasons. One, would vaccinations induce side effect with COVID vaccine? Would it trigger the relapse of aplastic anemia? Number two, will it give a patient protective antibodies against the COVID, so that if they get COVID, they have an antibody level which will protect them. So thankfully, what happened was there was an AAT sponsored study, which was predominantly run out of Leeds University by Professor Peter Hillman. And that has shown that aplastic anemia patients, be they be on cyclosporin, not on cyclosporin, treated long time back, treated recently, nearly 90% of them showed a response to COVID vaccinations in a very good way, a protective level of antibody, which is good, because we were worried, would it be 20%, would it be 30, would it be 40 or 50? Because some of the cancer patients were responding like 40, 50% responses. So it seems to be based on that study, which is a large study of 170 odd patients, that the response to vaccination was quite effective in patients with aplastic anemia. Number two, I don't think so any of the patients who had vaccines in that study had relapse of their aplastic anemia, which is reassuring. So the way I'm answering your question is, once you've had your fifth jab, if your protective immunity level or antibody levels are high, but unfortunately there are not routine available for testing those antibodies, but these antibodies last for a period of 6 months to more than 12 months. So if there is a protective antibody available, present, then I have been practically and pragmatically suggesting patients, like if you just had a, whatever they called it, spring booster, is it May time or April time? And if your protection is there for 6 months or more, why don't you wait and stagger it a bit later on in the flu season? Yeah, so that your protection is there, and also you get an extra protection later on. Yeah, so that you got enough antibody protection. And again, as I said, quite a lot of thing I'm saying is not based on data. It's just being pragmatic and practical about it. Yes, again, so we did show a large series of patients where so I'll take it in two different parts, Sam, if that's okay. One is around COVID infection itself. So when we had the COVID infection starting in March 2020, we collected a series of patients over UK, and unfortunately we had patients who had COVID infection, which triggered them to develop aplastic anemia. Yeah, so we had at least 3 patients where we collected that data, who had a normal blood count before COVID and then developed a COVID, and COVID itself temporally triggered an aplastic anemia process. So that goes similar to what I was telling you before, that any viral infection can trigger an immune system. And if that immune system is not just attacking the COVID, but it's also attacking the stem cells, that can relate to an aplastic anemia. We also did see COVID infection triggering the blood counts to go down in patients who had known aplastic anemia, i.e. you have aplastic anemia, the blood counts were reasonable, then they developed COVID and the blood counts went down. And quite a lot of people, we were able to rescue that. So that's around COVID infection. With the vaccination, as I told you, the large study from Leeds led by Peter Hillman, in that series of 170 odd patients did not show that vaccination triggered relapse of aplastic anemia in any of those patients who had aplastic anemia already. Yeah. But there has been a couple of reports, one from one patient from an Italian center, which was published, vaccine triggering relapse in an aplastic anemia or a new aplastic anemia in somebody who had a normal blood count. And there was a data from one of the German centers of 4 patients who had aplastic anemia and then had a vaccine, and that triggered them for the blood counts to go down out of their 120 odd patients they had monitored. So there are going to be always sporadic cases of these patients, unfortunately, who have a vaccine and then either develop aplastic anemia or relapse of their aplastic anemia. And again, as I said, unfortunately, the medical community is very good in reporting these cases, rather than reporting hundreds of thousands of cases who did not develop it, because that's how the medical community's reporting goes, which I know it's not right, but that's how it is. And unfortunately, we have also collected some data in the setting of post-transplant, where we've had a couple of patients relapsing their aplastic anemia after having a COVID vaccination as well. So again, as I said, unfortunately, in life, nothing is black and white. There are some situations where there is an increased risk and trigger as well. But predicting who is going to develop it, who is not going to develop it, is always a very, very difficult question to answer. Yeah, so like what we talked about, I think I would definitely, practically, I would stagger, I think so, rather than give it together. But it doesn't matter what you get first, what you get second. But in answer to my previous question, I told you, if you only recently had the, whatever spring jab, is it spring jab in May time, then you could wait for a few more months to get the COVID jab. So why don't you get the flu jab first and then get? So it's again more practical level answer rather than data-driven answer. The direct answer to that question is no. Yeah. And paradoxically, you might benefit because in UK, all the blood transfusions, or what we call it as packed red blood cell transfusion. So they don't have much plasma in them. So they do have a tiny bit. But if you're getting platelets and other things, it's got plasma, and plasma is the liquid bit of the blood. And the liquid bit of the blood, now, if you think 95% of the population in the UK has been vaccinated, and all the donors who are donating blood and platelets all have had vaccines, you will have a bit of antibody protection there. So you might probably getting a bit free there, I think, so through the plasma and other things. But I don't think so I've seen any data to say people on blood transfusions having a deleterious impact due to the vaccinations and not responding appropriately to vaccinations. No, they are different antibodies. So one, the vaccine-induced antibody is different to the protective antibody, which is given by the infection itself. Although the protective ability of both the antibodies will be the same, the type of antibody we test for somebody who had a vaccine versus somebody who had an COVID infection are different. So yeah, so you're right, Sam. So historically, shingles vaccine was always a live vaccine, and any live vaccine, we would suggest that any patient with a blood condition, be it aplastic anemia, be it other conditions like leukemia and MDS, we would advise them not to have any live vaccination at all because of various reasons, complications and other things. But the shingles vaccine now has got an inactivated form of shingles vaccine. And if I'm not wrong, it is offered to people over the age of 70 or people who have immune system which is abnormal, which would fit into the category of aplastic anemia. So these people can have shingles vaccine. the killed vaccine or the inactivated shingles vaccine. The downside of that is 2 vaccines. It's not 1 vaccine. You need to have a pair of them rather than one of them. So you are eligible for an inactivated shingles vaccine rather than the live vaccine. But the question is it safe to have a shingles vaccine? That's a different question, because that's where I've been answering right from the beginning. It's not just the flu vaccine which could potentially trigger abnormal immune system and could have a deleterious impact on the bone marrow. It's any vaccine could do the same as well. So one thing I've not mentioned is, say, if most people in this call have had a COVID vaccine and they felt a bit safe, there is a potentially possible that the flu vaccine could also be safe, because it's not specific to the flu vaccine. It's for any vaccination, because vaccination works by triggering the immune system. So it's possible that these things are safe. But again, there is always this thing in UK that we have always worried about flu vaccination in aplastic anemia, possibly because we would have thought, hey, before COVID, we always thought, okay, flu, okay, let me take to the bed for 10 days, get up and get away, rather than worrying about a vaccine which can make me to trigger an aplastic anemia. But we've been sort of, with the COVID, what it's shown is, yeah, these viral infections can be quite nasty, and the publicity around it, the bandwidth around it, the everything has gone at a higher level, that quite appropriately everybody is looking at it saying, yeah, viral infection, it's not just a simple viral infection. These could potentially be significantly life-changing to people as well. So it is important. I think I would suggest having further boosters, because there's been quite a lot of data, predominantly coming from, strangely, Israel and Qatar, because they were well ahead of the vaccinations in the curve when COVID started. So they were the people who showed quite a lot of data showing that people who had the third vaccines predominantly had a better protection and a prolonged protection compared to people who just had the 2 vaccines. So I would suggest yes, but sometimes I don't know. It's you can always argue saying, like, where do we stop? Is it like 3, 4, 5, 6, or so? But I think we just need to see what the data is showing over the next few months. I think what COVID has shown is that, which unfortunately the government and the general public haven't caught up on, is about being careful about all these viral infections, because they are all extremely transmissible. Yeah, because I travel by a crowded train every morning, and you just see how many people would, if one person sneezes, then if they had a flu, then you'll get at least 50 people will get it as well. So it's and I think that's where, I think, at least personally, I feel we didn't get it right, because if we had given a good mask mandate for people and other things, then it could have prevented. And again, it's people think they're doing the masking for themselves, but it's not for themselves. It's just you are protecting you from giving it to somebody. If you didn't know you had a virus, and you're just not giving it to other person, not just by saying I'm protecting myself from other person, because you are stopping yourself from giving it to other people. So I think it's quite a good thing to prevent other viral infections. Sort of masks do help as well in that context. So now, coming back specifically to the question, because I'm sort of divulging away, I think there's always general measures are always good to keep people safe, I think so. And I've always held this belief that even during the peak COVID time, totally wrapping yourself in a cotton wool and remaining in a cocoon is never going to be a good thing, both physically, mentally, psychologically, and stop you from getting COVID. Because I think you just need to be practical and pragmatic with these kind of things, and be careful. Yeah, around the household if other people are having flus and coughs and colds. Because at the moment, if we have people come into the hospital, at least in King's to hematology, we will check for about 20 different viruses, including COVID. So it is loads and loads of viruses. And my worry is always all these viruses going to come back with a vengeance, because they've not seen any humans for the last couple of years. So we just need to be extra careful until we know what's happening. And it seems to be it's coming at an earlier time point. We are already, in the last 4 weeks, we are already seeing different types of viruses: flu A, flu B, RSV, rhinovirus, and number of different viruses, because unfortunately the season is starting early as well. I think the one thing I would say is, from a COVID perspective, we think we understand it better. The complications with the newer variant and other things, it seems to be milder. Yeah, we do get number of asymptomatic patients carrying it without them developing significant complications. But that's not always the rule, because there are some patients who develop complications as well. So from a COVID perspective, I think I'm a slightly bit more relaxed about it because of the risk of it. We've got better treatments, we've got preventive treatments, we've got early treatments as well, because as you all probably should know and will know, if you do develop a COVID and if you have any symptom, you just need to contact your healthcare professional, because you will be referred to what is called a CMDU, which is COVID Medicines Delivery Unit, and there are many around the country. The GPs can refer, your local hematologist can refer, your nurse specialist can refer. So these people will deliver early treatment for COVID with antiviral medications or antibody treatments. So with that sort of protection and a bit of a license with us, compared to what we did not have anything in March 2020 or early point, when we didn't have any scientific data, we didn't know what we were doing, things are better. So from a COVID perspective, I'll be a bit more relaxed about it, within the boundaries, But for other viral infections, I would definitely be extremely careful about it. Some of it is disappointing as well, the way things have been done, because I'm not saying that's a groundbreaking treatment. It is a good treatment. It will help a proportion of people who have been unable to mount. Okay. Should I just go backwards and just give a bit of brief overview? Okay.
Yes, please.
Sorry. So there are still a group of people who do not mount a response to COVID vaccination. So for those group of people, there is a drug which Sam was mentioning called Evusheld to give it to prevent COVID in people whose immune system is not able to mount protective antibody responses against COVID vaccine. So which means that if you have the drug on board, it will protect you possibly from getting a COVID infection. So that drug has been, so we call it as a pre-exposure prophylaxis, that prior to getting COVID, you are getting that prophylaxis. But and it's a combination of two antibodies which help to work against the COVID, or virus doesn't get attached to the human cells. And this is only approved before being exposed to the risk of COVID infection. But unfortunately, the government did not approve this, and hence it's not been approved in UK. The success of this drug is variable, because the trials have shown that the risk of developing COVID is prevented between 20 to 77%. So it's a very varied thing, and which is why I think government always looks at the efficacy type of thing. Is it how effective is it versus the cost versus the benefit for? And unfortunately, it has not approved this treatment. So that's what Sam was asking about. And there has been significant lobby from cancer charities like AAT, and number of other diseases where the immune system is not up to speed. to see whether the government will reverse the decision, but probably they've got other things on their board at the moment, is it, with the government? So maybe they're not looking at it yet. It's a combination, because cyclosporin, so if you look at gradations of risk, if I can grade it like that, people who are on cyclosporin higher doses will have an increased risk. Yeah. People who are on lower doses potentially could have a lower moderate risk as well. People who are off cyclosporin, the risk is low, but it's never negligible, because you do not totally take away the immune system abnormality in the context of aplastic anemia, which is why there is always this potential risk of aplastic anemia relapsing down the line, because you've not totally abolished or corrected that immune system. You only dampened it and pushed it away, so that your risk of getting that infection, getting immune system to be up to speed is lower. I think it's very difficult, is it, Sheila, with that type of thing, because temporally it might be related, but we don't know about it. I don't think so there has been much studies done around flu vaccination and PNH treatment, and one of that you're talking about is ravulizumab, which is given every 8 weekly for other people who are not aware of the drug. But it is a difficult one. Like what you said, you have avoided for all these years up until 5 years back, and you probably are thinking, should I have avoided then as well? So that's why, as I said, it's a risk benefit balance at that, and everybody can make the individual decisions.